Hi, it's a pleasure to be here. I'm Ayelet Akselrod-Ballin. I'm the VP Research of Zebra Medical Vision, and together with me is Mark Robbins, a computer vision machine learner researcher from our research team. We will discuss today deep learning solutions for real-world healthcare applications. At Zebra Medical Vision, we bring a large, diversified AI medical imaging portfolio with 7 FDA clearances and 10 CE marked products. Our portfolio includes a wide range of modalities and applications, including vertebral compression fractures identification, coronary calcium burden detection, intracranial hemorrhage identification. Also, we have solutions for chest x-rays such as pneumothorax and pleural effusion, and a solution for breast cancer in mammography. We recently expanded our AI capabilities into new healthcare segments such as orthopedics, where we perform 3D reconstructions from 2D x-rays. I will focus today on what it takes to develop such real-world solutions, touching upon the various applications I just mentioned. I will begin with describing the concept of validation as we see it, and then dive into an example of mammography where I will bring a state-of-the-art comparative study that was recently published and also demonstrate the excellent results Zebra achieved in this domain. We will also talk about generalization in the context of ICH, where Mark Robbins will present a recent study we performed on generalization in ICH. We then will talk about scaling up with multimodality, combining images and text and what it takes to make this work. Finally, we will bring example from the population health domain in applications of vertebral compression fractures and coronary calcium burden detection. We will show how we perform large studies in the wild in these applications. So, as we all know, deep learning systems have reported to achieve human or even superhuman performance in the computer vision literature. And also in the healthcare domain, we have seminal papers in a broad variety of applications, including skin cancer identification, diabetic retinopathy, cardiovascular risks, and more. Still, when these systems are deployed in the field, their performance is often far below the expectations set by the benchmark in the lab. In other words, we can find a gap between the benchmark lab performance and the real-world field performance. With more and more companies entering this domain, I think it's important to discuss how to make sure that your system will actually achieve the preferable wanted performance from the lab also in the field. Now, one of the important things to consider, in my opinion, is how you perform your validation. Validation is actually not a validation on a specific test set, as one would tend to think about it when developing an algorithm. Actually, validation includes, in my opinion, a broad spectrum of components. The first one is to compare yourself to the prior state of the art, both in literature and previous products out there. Another component is to compare yourself to human performing clinicians and radiologists, for example, to make sure that you can augment their work and bring actual value to their workflow. A third component, when you want to regulate your product, is to consider building regulatory acceptable test sets. And these sort of test sets, when you want to, for example, regulate your product in the FDA, should include specific distribution and representation of specific findings and populations. This is not necessarily what is represented in the real-world scenario, where you can find lower prevalence of rare findings and so on. And therefore, it is important to test yourself and validate yourself before deploying the product in a wild scenario where you have authentic real-world patient data coming from different institutions which you test yourself on. And finally, the most important thing that one should take into account is to fully embed your clinical workflow in an authentic institution out there where you will actually see the high variability of the screening protocol and see how you adjust to them. You can see how the socio-environment factors impact the model performance and use in the actual field. And today, in the next slide, what I will give is several examples both that we have come across, and also I think there are some interesting ones coming that you can see in the literature. The bottom line, however, is that I think it's important to perform the full spectrum of validation, including the real clinical world validation scenario. Before diving into the specific paper dealing with mammography, I will briefly give some context about breast cancer. So breast cancer is the second leading cause of death from cancer in women. However, it is well known that early detection and treatment can considerably improve the outcome, and therefore many developed nations have implemented large-scale mammography screening programs, with the US and the UK alone having over 42 million exams performed per year. Still, despite the widespread adaptation of mammography, the interpretation of these images is very challenging. And you can see here a graph taken from Lehman et al., a paper that came out in 2017 in Radiology journal, where you can see the average radiologist performs around 87% sensitivity with 89% specificity. This, first of all, leaves room for improvement. And additionally, you can see that the variability in the performance of radiologists is pretty significant, where you can find that the lower performing radiologists are quite far away from the 87% or 89% specificity sensitivity. Therefore, computer systems have been trying to tackle this problem for more than 2 decades without significant success, until recently the revolution of deep learning has brought algorithms based on CNNs and pipelines that are based on deep learnings and very large data sets, where we can start to see the performance is reaching the level of radiologists. What you can see here is a table listing some of the recent deep learning approaches that have been reported in literature in the last couple of years. The first line includes the Lehman et al. Radiology 2017 paper, which is a study that was performed on a large data set of patients in the US, and you can see the performance of the radiologists that I mentioned earlier for sensitivity and specificity. The rest of the rows correspond to automatic approaches that have been developed in these last 2 years. And you can see here that in the first column, I stated the size of the training data set that was mentioned. And these data sets range from 30K patients in a multi-center data set to 576K exams, which we included in the Zebra Medical Vision when we trained our dataset, our approach for the submission to the FDA. Another important parameter is the amount of cancer images, positive images that are included in the dataset, and you can see that these numbers are very impressive, given the low prevalence of breast cancer in the population. Also, it is important to know that positivity for this type of application is actually usually based on a biopsy-proven breast cancer that was detected in the images. The third column brings the information of if localization information was included in this pipeline. And actually, this localization or information is obtained by manual detection or annotation of human radiologists of the data. You can see here that the approaches that did include annotated information actually obtained better performance in general, And this is very important since this tagging and annotation is very expensive, especially in the case of breast mammography, which requires specific expertise. Now, what it is important to conclude and note from these studies, the results are very impressive, actually reaching the level of radiologists, but they are studies that were performed in the lab. It is essential to assess which of these results will translate into a good performance in the clinical practice. And this is what this is exactly what the paper of Salim et al. Coming out very recently from JAMA Oncology in 2020 is all about. So the authors here performed the first independent evaluation of 3 commercially available AI algorithms for CAD in the domain of mammography, and their goal was to assess the screening performance when combined with radiologists. All these claims of AI compared and performing on par with radiologists in a specific domain are evaluated now on conditions which are separate from the lab where the studies and researchers and algorithms were trained in, on a new data set, a held out one with a different population, different vendors sometime. And here you can see that the results are actually very good. However, the lowest performing approaches obtained 0.92, while the best performing approaches obtained 0.956 AUC-ROC. And an important conclusion, one of the important conclusions that came out in the study was actually the volume of the cases is extremely important, perhaps even more than the diversity of the vendors or the patient population. This is very important to keep in mind when you are performing, when you're creating an approach and you're aiming to being able to generalize well to different types of populations. So you can see here that the lowest performing approaches trained on 6,000 cancer images and 106K normal images, whereas the top performing approaches trained on 72K cancer images taking with 680K normal images. Finally, to conclude the section on mammography, it is important to note some of the important conclusions that can be drawn out from these papers, state-of-the-art papers. First of all, there are commercially available AI CAD algorithms that can assess screening mammograms with sufficient diagnostic performance. Second, combining the first readers with the best algorithm identified more positive cancer cases than combining the first readers with second human readers. These conclusions have significant clinical impact. They lead to the conclusions that for breast screening mammography, the time has actually come to augment a human reader with automatic approaches, automatic algorithms. And in addition to that, it is important to understand what does it take? What does it take to get to this level of performance? And it was noted in the paper, and you can see very clearly that it takes a huge data set, a large multi-center data set. Of course, there are additional factors, including the inclusion of benign findings, the inclusion of localization information. Still, the best performing approaches are the ones that are trained on large data sets. This is what enables them to generalize well. To continue the discussion on generalization, I'm happy to introduce Mark Robbins, which will present our study and results obtained in the different modality of head CT and in the application of ICH.
Hi, everybody. My name is Mark. I'm an algo researcher here at Zebra Medical Vision. I'll be talking for a few slides about generalization, and specifically generalization in the context of intracranial hemorrhage, or ICH. So, of course, generalization is something that's really important for all of our algorithms, but ICH will just be the context I'm talking about it in today. So just super briefly, I'm not a doctor, so not the best person to go into any details, but the really quick overview is that ICH are brain bleeds. They can take different appearances based on what kind of bleed it is specifically. Here in these 5 images below are images of different types of intracranial hemorrhages. And the important thing to recognize is that for all of these different kinds of bleeds, they can all potentially require immediate intervention. Okay, so what does that mean for us here at Zebra? So this slide is kind of just like a quick overview of what the model pipeline looks like. So here on the top left, you see as soon as the patient undergoes that scan, that full 3D CT volume is then passed into a 3D convolutional neural network, which then classifies this scan as either containing a bleed or not containing a bleed. If it is containing a bleed, a few things happen. First of all, that scan is then reordered on the radiologist work list to be triaged up top so that they can look at this finding the most quickly before other series that are potentially less urgent. The algorithm will also output a key prominent slice where that bleed is most likely to be located, and a heat map on top of where the bleed most likely is to help the radiologist diagnose even more quickly and for them to understand the algorithm output better. Okay, so that's the super quick overview of what ICH is, what intracranial hemorrhage is, and now just kind of a quick overview of what the issue of generalization is. So the question here is, how well does the algorithm generalize to data not seen in training and validation phases? So of course, the setup here is that we at Zebra have our own training data and our validation and testing data to understand the algorithm's performance. But at the end of the day, the important thing isn't how well the algorithm performs in-house, of course, it's how well it performs on new institutions in new settings not seen in training and validation. And so we can ask this question of like, why do we expect this to potentially be an issue? Why might we be worried that our algorithm may not perform as well, in the real world deployed at new hospitals as it does on our own data? And these are just, there's a bunch of reasons we might be concerned, but here's just a few reasons to highlight. One reason may be different machines and scanner protocols. So, if a new hospital has a different settings that haven't been seen in training, we may expect that to trip the algorithm up. Different populations and disease distributions, maybe a new hospital has older patients or younger patients, or more of a specific subtype of diseases. And for that reason, our algorithm may, achieve, let's say, a sensitivity and a PPV different than what we report on our own data. And then another possibility are different technicians, maybe with different amounts of training. Maybe the image quality differs from institution to institution. So again, these are just a few, but just to generally motivate why this is something that we should be concerned about. And just to kind of continue to motivate this issue of generalization a little bit more, here's a slide where we ran an experiment. And in this case, we ran on a smaller amount of data than usual and fewer institutions than usual. And we basically trained an algorithm and then we tested it on 4 different institutions that all had the same scanner protocols, across a number of different parameters that we may expect to be especially important. So in this case, each column here, right, is a different institution where we're looking at the same machine brand, the same KVP, the same spacing between slices, the same convolution kernel. So basically in this case, we're kind of controlling for all of those factors that are the most important factors of that first bullet point before of machine and scanner protocol. And what we see here is that there's still a pretty significant variance from institution to institution. So this is, a big enough variance to be outside the 95% confidence interval. And of course, what the source of this variance is potentially difficult to determine. It could be one of those other reasons I mentioned. It could be, something totally unrelated. But just to kind of understand that, this is more, and this is definitely a bigger issue than just having the same machine. There are really a lot of factors at play here. Okay, so if that's what the problem looks like, what do solutions potentially look like? And in this slide here, I'll present an experiment in which we kept the total size of the training set constant, but increased the number of institutions contained in that training set. And this test set is comprised of institutions that are not seen in any of these experiments during training. So all the way here on the left, this number 1 is the case in which all 3,000 series in the training set were taken from one institution, whereas the case on the right, number 4, is the case in which we have 750 samples taken from 4 different institutions. Again, the held out institutions being separate from all of them. And what you see here is a few things, right? Of course, you see a tremendous amount of variance and noise between experiment to experiment. That's important, certainly important to take account of. You also see a, generally speaking, an increase in the generalization ability as you increase institutions. And you also see, generally speaking, a decrease in the variance between experiments, especially as you move on to 4 institutions. So I think there's a few things to highlight here, which is one, the importance of having a diverse training set and, paying attention not only to how much data is in your training set, but how diverse that data is. That's extremely important. And the other thing, of course, to pay attention is that this alone is really not a fix for this kind of concern around generalization. And there's really no substitute for having a super robust feedback loop with the radiologists actually using the algorithm to understand what the performance is like and how they're experiencing it. Thanks.
According to the generalization example presented, the size of and the volume of the data are extremely important. However, the well-known challenge in supervised machine learning algorithm is that annotated data is very expensive. This makes approaches that rely on weak labels and weak supervisions coming from radiology reports extremely attractive. Natural language processing focuses on analyzing text and speech to infer meaning from words in such report and is an important ability to scale up. Previous work in this domain, such as TextRay or Chexpert, works that utilized X-ray reports, have relied on rule-based approaches. However, NLP has evolved significantly in the last couple of years. The recent advancement adopting pre-trained language models such as Elmo, BERT, and GPT. The exploration of these models is now reaching the healthcare NLP domain. Transformer models pre-trained on clinical data not only reach state-of-the-art performance on many clinical NLP tasks, but they also help to overcome the shortage in labeled data that is also relevant in NLP. Still, these methods require a lot of time and resources for pre-training, and they suffer from all the problems of black box algorithms. Additionally, there is a big issue with the inter and intra-expert viability. Clinical experts rarely agree with each other, and here I will present an example, a very recent example or relevant example in the domain of chest-CT. An example to demonstrate the concept of noise and ambiguity that one can sometimes find in radiologist report is taken here from the application of COVID-19 detection in CT. So for identifying COVID-19 in CT, one would first look for GGOs, ground glass opacities, that are a descriptor consisting of hazy opacity that for COVID-19 have a specific distribution in the peripheral lower lobes. Additionally, another relevant finding is consolidation, which are a region of normally compressible lung tissue filled with liquid instead of air. Challenging negatives in this case would include bacterial pneumonia or other viral pneumonia, lung nodules, and COPD. So when you want to rely on weak NLP labels, these are the findings that we would look for, and these are the negative cases that we would be careful from. And now let's view this sentence that was found in a relevant radiologist report. Some small areas of more dense opacities are seen in the peripheral right lower lobe. This appears more infectious, inflammatory than mass-like. Looking at the sentence, first of all, it's very vague. It's not clear how much more dense. Can we exclude mass? Can we label this as pneumonia? It is not clear if the exam falls into the positive or the negative bucket. As you can see below, there are two relevant examples or visual examples that you can compare to. This is one exam consisting of the ambiguity challenge that we come across when developing algorithms and when trying to provide ground truth labeling based on NLP. To sum up this point of the ambiguity and noise that can appear in radiologist report, it is apparently well known that radiologists don't necessarily always commit to findings in the reports, and a lot has been said about radiologists and hedging. Still, utilizing radiologist report is extremely valuable, and utilizing NLP algorithms and weak labels is extremely valuable for generating larger data sets, improving your performance, improving the ability to generalize to data sets in the field and in the wild. It is just important to keep in mind the effect of this noise and to carefully analyze it. And there are, of course, many solutions for it, such as label cleaning, data reweighting, curriculum learning, and so on. An interesting example in this context is our work on osteoporosis and vertebral compression fractures. The annual incidence of osteoporotic fractures in the US is higher than the incidence of breast cancer, heart attack, and stroke combined. The most common osteoporotic fractures are those which are called vertebral compression fractures. In addition to being a source of morbidity, VCFs indicate substantially risk of future osteoporotic hip fractures. 1 in 2 women and 1 in 4 men over the age of 50 will suffer from an osteoporosis-related fragility fracture. Over 50% of hip fractures are preceded by a vertebral compression fracture, serving as an early warning sign of increased fracture risk. Yet despite the burden of this disease in an aging population, osteoporosis screening remains profoundly underutilized. Treatment of osteoporosis are widely available, evidence-based, and cost-effective, but a considerable diagnostic gap exists to identify patients at risks of fractures. There is therefore clinical value for identification of incidental VCFs on CTs as a predictor for future osteoporotic fractures. We have developed an automated VCF solution based on neural networks trained on a large dataset indexed according to the Gannat classification. The device was validated against previously unseen dataset, achieving high performance at detecting moderate or severe vertebral compression fractures, and received FDA and CE approval. You can see here highlighted in yellow 2 examples. One is the case of a 78-year-old male where you can see severe VCF, which is a true positive. On the right, you can see an 83-year-old female. Again, here you can see multiple compression fractures and schmorals. In addition to the type of validation with an unseen data set approved by the FDA, we have performed several studies in the wild. We have seen similar potential for the opportunistic screening model in another large-scale study we published in Nature Medicine earlier this year, wherein close to 50,000 patients followed up for 5 years, CT biomarkers improved the AUC for predicting actual fracture events when compared to utilizing the FRAX alone. In order to further validate the potential clinical impact of this device, we applied the device to over 76,000 chest or abdominal CT scans from the US and reviewed the original radiology report through a combination of human review and NLP. This established the baseline rates of VCF reporting. The device demonstrated a 138% increase in detection of moderate or severe VCFs from the established baseline. The visual sub-analysis of the CTs verified the algorithmic performance and revealed the high NPV and moderate PPV, which you can see here in the slide denoted in yellow. However, review of the false positives showed a large majority to contain mild vertebral compression fractures, which were classified as negative for this study, still conferring clinical value, and this is also denoted here in yellow. The VCFs were identified in 6.6% of the 76,000 radiology reports. The algorithm obtained a similar performance. Therefore, we conclude that there is a clinical value for identification of incidental VCFs on CTs as a predictor of future osteoporosis fractures, and that the device can perform and do this automatically. Another interesting example, also in the domain of population health, to which we have been applying large-scale studies, is the problem of coronary artery calcium burden identification. Cardiovascular disease is the most common preventable cause of death, accounting for up to 45% of the mortality in Europe and 30% in the US. Effective lifestyle and pharmacological prevention is available, but identifying those who would benefit most is an ongoing challenge. Coronary artery disease accounts for 50% of all the cardiovascular-related deaths, making coronary calcium a powerful predictive biomarker for cardiovascular disease. Coronary calcium has been traditionally quantified using dedicated ECG-gated cardiac CTs. However, cardiac-gated CTs are dedicated studies and are typically used to visualize the heart. Thus, this cohort of patients are already under investigation for cardiovascular disease as opposed to non-cardiac gated CTs that are being performed for many indications, to which we have been developing our new device. Therefore, we developed a deep learning-based system to detect and classify coronary artery calcium burden on non-cardiac gated CT scans. The system was trained on a large cohort of patients with coronary calcium lesions and classified patients into mild, moderate, or severe coronary calcium burden based on a scoring similar to the traditional Agatston systems. The device showed great performance results with high overall agreement between the established ground truth and the device itself. As you can see here, the flowchart of the system includes several steps. First, the input is a non-gated, non-contrast chest CT. Then we perform heart localization and automatically segment the coronary calcium. After that, we compute the coronary artery calcium score similar to the Agatston system. And finally, we produce an output with an annotation of the finding, as you've seen in the previous slide. We further took this device and applied it to 20,000 routinely acquired non-gated, non-contrast CT examinations. The radiology report of these same CTs were reviewed for documentation of coronary calcium, and we compared the algorithmic results with these reporting. What was interesting to see that the actual frequency of writing reference for coronary calcium was remarkably low in all categories, measuring just 5% even in individuals with high coronary calcium score above 400. This is an example of the use of automatic quantification system that has a huge potential to capture opportunistic cardiovascular scanning in routine CT chest imaging and guide more patients into appropriate care and treatment. To sum up some of the takeaways from today's talk. First, for deep learning algorithms to bring real value to healthcare, they must go through a spectrum of validation. Most importantly, they must be validated in the real clinical workflow. Second, in the breast screening domain, we went through various state-of-the-art papers. It is clear from all of them that the time has come for AI augmentation of the radiologist in mammography screening. Third, in terms of generalization, both the mammography literature and our own ICH research demonstrated that the volume of the data and its variability are the most critical factors to promise good generalization in the field. When developing generalization approaches, it is very important to take into account that the source, the target, and the supervisions are not always available simultaneously. When increasing volumes and scaling up with multimodal algorithms and weak labels, the label noise should be carefully considered. Additionally, we presented 2 examples in the population health domain. We presented large-scale studies evaluating automated VCF identification of incidental VCFs in CTs and automatic coronary calcium quantification software that can serve to capture opportunistic screening for cardiovascular risk in routine CT chest imaging. Both these types of applications have a huge potential impact to guide patients to appropriate and better care. Our work at Zebra Medical Vision is dedicated to bring genuine impact to real-world healthcare. Finally, I wish to thank the entire Zebra Medical Vision team that makes all of these results and projects become possible, and especially to the exceptional research team for transforming healthcare with AI to bring better care with real-world solutions.